Hello, everyone, and welcome to another audio podcast on in this series on the LabZtorm critique. This is the scientist, and I'm going to be talking about the in this series around the LabZtorm critique. I'm going to be talking about an important topic relating to hematuria and test and investigation or testing to improve patient outcome. This is another ZtormLabostix production in collaboration with the Renal Patient Support Group, or the RPSG, and this is on the series the LabZtorm Effect v.2, and I'm going to start off by highlighting a little bit about what hematuria is. So, generally speaking, hematuria can be a symptom of acute kidney injury or chronic kidney disease, but diagnosis is often hampered by the lack of clarity with regard to description, analysis, and referral criteria. So, in this paper publication that's come out of the Renal Patient Support Group, and this was a paper publication that was published in the Biomedical Scientist in May 2015. In this work, this is an overview of this subject entity. So the causes of hematuria are as such. So asymptomatic hematuria is often caused by inherited thinning of the glomerular membrane of the kidneys. It can be sometimes it can sometimes be dismissed as being due to contamination with menstrual blood, or to the urinary, or related to a urinary tract infection. Many studies of the causes of hematuria have examined patients referred to nephrology clinics or urology clinics, and have not used, for example, what's referred to as phase contrast microscopy to differentiate between glomerular and non-glomerular sources. Now, hematuria in adults is more often due to bleeding from the glomerulus than from elsewhere in the urinary tract. In unselected individuals with glomerular hematuria, a renal biopsy is most often illustrates basement membrane disease, or can help to detect or understand whether basement membrane or glomerular basement membrane disease exists. And this condition is characterized by thinning of the glomerular basement membrane on ultrastructural examination, and a very mild proliferative glomerulonephritis. The thin basement membrane disease is also known as benign familial hematuria, and other family members may have hematuria as well. Affected individuals typically have lifelong glomerular hematuria, minimal proteinuria, and normal renal function, as well as often having a family history. Now, backtracking a little bit, so that's some of the causes, and in relating to this condition, backtracking a little bit, the source of and reason for hematuria is often confused, or can be confused, due to the lack of clarity over description, analysis, and patient referral criteria. A thorough hematuria review has been carried out, and as a result, the Renal Association retrospectively, along with the British Association of urological surgeons have formed a joint working sort of group or organization or effort to agree on guidelines to update training of staff and healthcare professionals providing care for patients presenting with hematuria. Urinary screening for hematuria should only be performed for recognizable medical reasons, as there is presently no evidence or little evidence to support opportunistic point of care testing for the general population. The nephrological aspects of analysis and control have been covered by the National Institute of Healthcare Excellence and the chronic kidney disease guidelines, which replaced the existing the former or existing guidelines that or framework that were aligned to the UK that came out of the Royal College of Physicians. So in this work, the authors have looked at hematuria and provided a sort of an overview of the topic. And from a primary care perspective, it is perhaps also important that healthcare scientists appreciate or understand the different sort of criteria along with the sort of the curriculum that comes out on this from a primary care perspective, because of the kinds of the symptomology that is relating to hematuria can be related to other conditions, and so therefore scientists from a laboratory perspective should ensure that they have the most up-to-date understanding around the different curriculum aspects of areas of practice around hematuria that would normally be aligned to GP practice as well, so that in some regard it's staying ahead of areas of practice around this particular condition. Now, in this context also, hematuria is defined as the presence of red blood cells in the urine, either visible, which is referred to as macroscopic hematuria, or detected by direct microscopy, which is microscopic hematuria. Substantiated numbers of red cells or red blood cells have provided ranges used for the classification of microscopic or occult hematuria, with established definitions using values of more than 3 red blood cells per high power field, or greater than 5 red blood cells per high power field. Hematuria can be broadly classified as nephrological or urological in origin, as sort of briefly highlighted before. Any glomerular disease may result in microscopic hematuria. Active glomerular nephritis and acute interstitial nephritis are associated with large numbers of usually dysmorphic, so abnormal looking or appearing red cells, and what's also referred to as red cell sort of casts. So basically, where the different stages of the red cell sort of appearance within normal physiology. Other reasons for hematuria also include or can include non-visible hematuria, which is related, which has the abbreviation as NVH, which is connected to the lower urinary tract, and these can include reluctance to void or wanting to empty the bladder, avoiding frequency, avoiding desperation or painful voiding, dysuria, and another aspect to this is where there's asymptomatic non-visible hematuria. So you have non-visible hematuria, and you have asymptomatic non-visible hematuria, which is an incidental finding really in the absence of lower or upper urinary tract symptoms. Microscopic hematuria may also be detected in the absence of any underlying pathology, such as for example, vigorous activity. So what I just want to have, so there's this add-on here. There's an add-on where, for example, male versus female urinary tract. The females have smaller urethras versus versus males, and so thus in females they're more viable, or more susceptible, I should say, to having issues around the urinary tract, because of the length of the urinary tract or urethra is shorter, and that's a sort of a natural a natural aspect around pathology and anatomy. And then I'm now just going to highlight that from a sort of a epidemiological standpoint, a public health and epidemiological standpoint, hematuria is relatively common, is relatively a common finding to some extent, and has many potential underlying causes, ranging from physiological to life-threatening. The prevalence of hematuria on what's referred to as a dipstick testing has been studied or investigated in several population groups, such as patients attending a hospital, or outpatient, sort of referred to as outpatient appointments, in occupational health programs, and in large medical insurance health screening programs, and have been found to range from anything from 2% to just less than 20%. A 16% retrospective study of hematuria using urine microscopy shows a prevalence of 1 to 5%. However, the range varies on the definition of significant and what's referred to as significant hematuria. Although, as mentioned, listeners, previously, hematuria that's aligned to glomerular basement thinning or glomerular basement membrane type hematuria would be referred to as most serious, because then what happens with that is that there's more probability or more risk of individuals losing renal function or kidney function over time as well. Now, in this paper publication, there are other areas, and I won't say everything here, but I won't read the whole thing out. But there are aspects around differential diagnosis. There's aspects around imaging, indications for referral, long-term monitoring, and some aspects around research perspectives as well. What I will highlight just briefly on this, around this though, is sort of the aspects that relate to the key indication, the main indications for referral. So evidence of this, evidence for referral based on guidelines that were those that are based around from the Renal Association, and also the the British Urological Society, and these are guidelines. These refer to these indications are for referral based on practices that have been used and implemented. Obviously, in literature, that literature, more recent literature, some aspects of the referral criteria, indications for the referral might be updated, but generally these are some preliminary indications which still stand sort of the test of time. So around hematuria, so evidence of visible macroscopic hematuria, which is a general concern. This usually requires a fast track urology referral for imaging and cystoscopy, unless strong pointers in acute strong pointers to acute renal disease. Now, referral to nephrology specialists is important if urology investigations prove negative, because what should happen is that even if it's negative under, and testing investigations are negative under urology perspective, in nephrology perspective, they may well be they may differ. And so invisible microscopic hematuria without proteinuria with a GFR or glomerular filtration rate of more than 60 mils per mil is also important. Patients who are older than 40 years with consistent evidence of hematuria require referral to urology, recommended, and this is recommendation based on that aligns with also aligns with age and ethnicity, and they may and aspects around that may vary sort of regionally or nationally as well. Patients either less than 40 years or more than 40 years with negative urological investigations potentially require the same management as would be the case in CKD stages 1 and 2. But it is important to validate screening results with imaging. So in some contexts, you can't have one without the other. So if it's negative, if things look negative on imaging but look positive on screening, then still it's important for it's an important indication for referral, and vice versa to some extent. Now, patients with evidence of microscopic hematuria with significant proteinuria, where they have an albumin creatinine ratio which is with a raised albumin creatinine ratio, and where they have where there is evidence to point out that there is a PCR test, polymerase chain reaction tests and investigations to inform that there is proteinuria that is evident, then that's another indication for referral to nephrology. Now, the final thing I'm going to say is that there are some points, some final points I'm going to make here. There are relatively few trial-based data regarding the effectiveness of screening for hematuria in the general population, and to identify life-threatening pathologies. Confirmation of hematuria using microscopy sort of remains a valid or viable option where further investigations are being considered. A stored sample or stored samples are theoretically subject to degradation. The practice of sending, for example, a urine sample taken in the community for laboratory analysis of hematuria appears to be questionable value, to be of a questionable value, although such samples may still be useful to eliminate urinary tract infection as a cause of hematuria. So there is probable sort of indices to implement that from in some regards from a screening perspective, at least as part of baseline investigations. Campaigns in public and medical communities can help to delay, perhaps even prevent the development of chronic kidney disease. One such example of raising chronic kidney disease awareness through, for example, in and around, again, social media is by our collaborators, the Renal Patient Support Group, or the RPSG, and many cases of chronic kidney disease can go left unrecognized, but the condition can be treated even at late stages. So point of care testing is always advantageous, although even in sort of more recent times, point of care testing again hasn't really kind of leveled out or been really implemented or focused or implemented related to hematuria as such. But I'm going to leave it like that for now on this audio podcast. This has been on hematuria and improving patient outcome, and there's lots of different ways that can be implemented. I look forward to highlighting another audio and podcast on another important topic in soon. And this has been The Scientist. This is the LabZtorm Effect v.2 audio podcast series on the LabZtorm critique. And it's been another ZtormLabostix production with the Renal Patient Support Group, our collaborators. And thank you for taking time to listen on this important topic.